Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Robbie Hughes, CEO and founder at Lumeon. Robbie, welcome to the show.
Hey, Matt. How are you doing? Thanks for having me.
So, Robbie, what I always like to do before getting into the main part of the conversation is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Robbie, the floor is yours.
I'm an aerospace engineer by training, but I've worked my entire professional career in healthcare. I know a bit about software. I've learned how to code, but I know enough to know that I shouldn't be doing it full time. I started the business in the UK, hence my accent. We brought it over to the US a few years ago, and I'm delighted to say we work with some of the largest healthcare organizations on the planet, helping them deliver better care more predictably and more affordably.
That sounds great. So, kind of as you said, if you're an aerospace engineer by training, what got you into healthcare in the first place?
Well, so I developed this kind of curious interest in systems engineering, which is essentially the idea that you want processes to be reliable and predictable, and you want to be able to understand that when you do something over here, it then has a predictable and reliable output over there. And obviously, that's kind of important in aerospace. When you go up in an airplane and you want it to stay up, and when you push a button, you want to know that the thing is going to do what you expect. And there's a long history of kind of really interesting and fascinating discoveries in aerospace where, they've thought about cockpit design, they've thought about interface design to improve reliability and improve the failure rate, frankly. And they take this very, very seriously. If there's anything that ever happens in aerospace, it is deeply investigated, and there's a real culture of transparency. And that said, my mum is a doctor, my wife is a doctor. I'm entirely surrounded by doctors, and so I got interested in the delivery of medicine. And what I saw in medicine was a lot of incredibly smart people who are incredibly well intentioned, but I didn't see that same sort of reliability. And I thought, this is crazy. How do we have it in one industry but not in another? And my kind of journey since then has been a journey of discovery into how do you improve reliability in healthcare delivery. And that's really what Lumeon's all about. And it turns out there's a lot of opportunity, but there's a lot of stuff that's pretty simple to describe that it turns out it's incredibly hard to do in practice. And so here we are today, now 15 years later, and we're still doing it. So,
that sounds very incredible. And kind of maybe unpacking that a little bit. How were you trying to introduce that reliability and that predictability into healthcare? Maybe pathways or systems. Because as you said, there is a lot of complexity there, but I do imagine that there are ways to I don't know if simplified is the right way to describe it, but to just get it so it's more consistent.
Yeah, so I think there's a lot of different things to unpack here, but fundamentally it boils down to this idea that there's been a lot of time and money invested in helping physicians make better clinical decisions. So clinical decision support tools, pathways, etc. So there's kind of a reliability or a variation issue around clinical decision making that's pretty well understood, and that people have made a lot of investments into that now are driving a huge amount of improvement. So that's one part of the problem. The other part of the problem, which we're more interested in, is that operationalizing a clinical decision isn't the same as a physician just documenting that it happened or placing an order. It requires an entire team of people to be precisely choreographed and coordinated to do the right thing for that individual patient. And the problem is, the more levels you get removed from that individual clinical decision, the more opportunity you get for Chinese whispers and handoffs and frankly, systematization and reliability issues that then cause erosion in the kind of predictability of that original decision. And so you end up with this slightly bizarre world where if you have a choice between two different clinical decisions, where one can be perfectly choreographed and is 100% reliable, but maybe it's not clinically perfect, versus another decision where you could have a really strong clinical decision that maybe hits the nail on the head first time and is maybe cheaper to do, but requires a level of choreography and coordination that is just not practical and so won't happen so often. Well, which is the better clinical decision? And that to me is a question that's not really been explored. And you see evidence of it in areas like oncology where you get, extremely, and IVF is another one where you get really strong coordination of the process because you've got to get everything absolutely right in order for the thing to work. But that's pretty absent in a lot of other areas. And there's tons of stats around this. Like in the case of a patient being discharged from hospital, we know that if they've got heart failure, we need to follow up with them within 7 days with a PCP. But that, in many cases doesn't even happen half the time. So, those are reliability issues that dramatically impact both the quality and cost of care, but also the outcome. And that's what Lumeon is really built to address.
Yeah, so looking at that coordination, the choreography, what are some of the components that go into kind of building that out and enabling it? Because as you were just saying, that might be the more difficult part around what is arguably a relatively simple clinical decision that's very effective, but then being able to follow through is where the kind of the rubber hits the road.
That's right. So I think there's a couple of things. First is this isn't really a problem that you get when you're a lone PCP working on your own with a few patients. This isn't a problem that existed when medicine was very much still a craft and people were working kind of on their own with their patients. This is a problem that has evolved as we've tried to scale medicine and turn it into a much more of an industrial thing with multiple people doing multiple things. And so what we're seeing are effectively complex team and communication related issues rather than issues of intent or ill will or whatever else. So that's the first thing. So the question is, how can you impact this? And again, there's some infrastructure that's required. Like the first thing you need is the data. You need to understand what's going on with the patient. And part of the issue with that statement is that the data in the EMR is not necessarily as reliable or as complete as we would like. A lot of it's in free text. And a lot of it is documented for the purposes of billing, for example, rather than understanding necessarily the presenting complaint or some of the more kind of subjective areas around the patient. So data is important, but the data that exists in the EMR is sort of necessary but not sufficient. So the first hurdle you've got to overcome is if you're going to try to do this in a way that is going to be effective, you need to have a more complete and more robust picture of what actually should be happening for that patient. The second thing you need on it is a sort of an understanding that every patient is different, which kind of is it goes without saying, but it's not enough to do the same thing all the time. And I think a lot of these systems or a lot of technology kind of suffers from the idea that they'll put in, and you used the word pathway earlier, but this is a good example. They'll put in pathways where it will say, do this, then this, then this, then this. And somehow we then get confused when these systems don't work. Well, obviously they're not going to work because every patient's different, every circumstance is different. So you can't have technology that's going to try to force fit patients down preset processes. Somehow the thing has got to try to personalize itself to the needs of the individual patient. And of course, the decisions made by the care team. So that personalization aspect is absolutely foundational and obviously requires the data that we may not always have underneath for it to work. And then the third bit, and this is something that you get through, I just guess kind of bitter years of experience, is it's got to work in a durable way. And what I mean by that is it's not realistic to expect things to work perfectly. Patients are not going to be compliant. Care teams are not going to be compliant with 100% of things all the time. And so in the event that we see a lack of compliance or we see people kind of veering off piste, it's got to be able to course correct and understand what is reasonable and appropriate for it to do. And it's got to be able to do that instantly. So you can't have a system that's kind of going to batch process stuff overnight and work out that tomorrow we're going to do things differently. When someone's going off track right now, it's got to work instantly. So there's sort of multiple layers of things that have to happen, all of which are technically interesting and complicated in and of themselves. But without all of them, you can't do any of this stuff. And like I said, 15 years is a relatively long time, but it's just about the right amount of time for us to work out how to do those three things. So here we are.
Yeah. Yeah. And I think as you're kind of pointing out, all those three things are very complicated. And, the personalization point that you raised to me seems very key, because it even, as I was listening, fed very much into your description around durability, because that durability, if I was hearing correctly, is about enabling even further personalization and customization as an individual's response changes. Yeah, so kind of from that perspective, can you dig into a little bit more in terms of, what were some of the what are, I should say, are the technical challenges around enabling that personalization in a technology or other system?
Well, so again, without giving away all the secret sauce, the practical reality is you've got to try to work out how are you going to take. And again, you made the right point. Like the personalization and the durability are effectively coming from the same place, which is the system's got to look at a patient in the context of a process or a diagnosis or whatever the framework you're using. And it's got to be able to work out right now, what is the thing that I've got to be able to do? And that, well, in a practical sense, from a technical point of view, what it's doing there is constant analysis of a huge amount of streaming data coming from the EMR. And it's using that then to look into what we call the pathway engine, but looking into the pathway engine, look at what we believe is supposed to happen, look at what's actually happening, and then try to say, okay, based on that, we need to do X, Y, or Z. There is a lot of people, when they hear this, they say, okay, you must use a lot of AI and machine intelligence to be able to do this. And there are some particular breakthroughs we've made which allow us to do this scalably and quickly. But AI is kind of interesting, and I know probably about GPTs and LLMs and things like that. And the last thing you want in this kind of space is hallucinations or the system making something up. Or essentially, this works because care teams trust it and they know it's going to work 100% of the time. As soon as you get into this universe where there's some doubt or hesitation or risk that maybe it's going to it's not going to do what you expect, then you end up with a human in the loop situation. And as soon as you've got a human in the loop, then what happens is effectively the machine is just recommending something to the user, whoever they may be. They've got to then check it, and then they've got to authorize it. And that takes time. It creates potentially a false sense of confidence. And then you lose credibility, and you can get into some fairly nasty situations where care teams are not seeing the outcomes they expect, mainly because they don't trust it. And what's kind of interesting to me is healthcare is fundamentally a business based on trust. Like there is a trust from the patient to the caregiver that they're getting the right advice and they're going to do the right things and so on and so forth. And there's a trust between care team members that what they've done is going to be right and so on. But it's very much a human to human trust. So I trust that Matt is doing the right thing, etc. And but there is no kind of human to process trust. And as a consequence, there's very little process to human trust. And so everything that we do in healthcare is ultimately some sort of evidence-based process, or not everything, but by and large, that should be the case. But there are no measures that we examine. There's no kind of systematization. There's no examination of whether the things that we're doing on a process and operational basis are actually effective or varying from what they could be. And so I think this is interesting. Like the bar for machine-based things is very, very high because we automatically assume that we're not going to be able to rely on it, and therefore that it has to deliver perfectly. But actually, in practice, the standard for reliability in healthcare is pretty low. And like I said, we trust the humans, but we seem not to get the output we would expect from that level of trust in the processes. So I think it's interesting, but fundamentally, this stuff works because there's a machine model that is reliable, that delivers personalization, and it creates reliable processes that then people trust in, and you get that kind of skyrocketing improvement.
It's an interesting point around the trust and you being able to measure how effective a process is. And for those of you just joining, I'm talking with Robbie Hughes from Lumeon, talking about kind of reliability and translating system engineering into healthcare. And Robbie, picking apart that kind of trust in the process point that you're just raising, have you seen any evolution of of measurements to improve kind of an evidence basis for the reliability, or kind of where do you see that piece of it going? So it's not just we're trusting in that human interaction, and maybe that does help advance some of the more technology driven supports that can be created.
Well, I think it depends on your point of view around who's really in the driving seat here. So if you believe that the physician is in the driving seat and they're making all the decisions and they're accountable for all of the outcomes and everything else, then and there's nothing wrong with that worldview. It's definitely the predominant worldview. Then what you're doing is you're sort of accepting that, for better or worse, they're going to make the best decision they possibly can. But all of the downstream consequences of those decisions are somehow going to flow back to them, but they can't possibly control or have any visibility into them whatsoever. Mainly because they're working with other patients, but also it's not really their job. We don't want them looking at downstream processes. And one of the things I always look at is, when we work with a customer, do you talk to me about your SLAs, your internal operational metrics? And most people look at me with a blank face. They don't know what I'm talking about. They don't even know what the three-letter acronym SLA means. But to me, these are very basic, very simple things that tell me that you've got some sense of an understanding around what you would expect normal to be. And off the back of that, you have some sense of understanding of what variation from normal should entail. For us, how that stuff manifests from a system perspective is we'll have these pathway frameworks, and they are littered with SLAs, and we use the SLAs to understand that not only has something happened, but if that thing that's happened results in a downstream action that is then going to have consequences if it's late, because you've got dependency chains. We know all of this stuff, and variation in execution, both from a quality perspective, but also a timeliness perspective, has a huge impact on what happens. Like you miss a discharge window because an MRI doesn't come back on time. That's a huge economic consequences. But if we had an SLA around the MRIs, for example, or further upstream as you get into scheduling and referral there's all these things that can be better managed, but they're sort of done on a best efforts basis. The thing that kind of gets me excited is when I look at overrides in our system. So how many times are care teams looking at what the thing is supposed to be doing and saying, actually, stop, do something else? And if that number for us wants to be less than a couple of percent, like in 98, 97% of cases, the system should come up with and be ready to execute the right thing for that patient. And in the case that a clinician disagrees with that, they can stop it. But that's a marker of the right kind of trust. And it also, by the way, creates a really interesting data set around some of this variation. Because it may well be that a clinician would say, actually, don't do this, or order something else, or follow up in a different way. And that's an interesting data point that we can then analyze and say, well, you know what, 30% of your clinicians are actually making this decision and overriding it and overriding the recommendation. Does that mean our best practice protocol is wrong? Well, let's talk about that. And that conversation is, I think, a really interesting conversation to have. So a lot of what we end up doing ends up prompting better quality conversation internally around how the practice of medicine can be improved.
And that raises a great point. It seems like it also connects back into the point you were making right before that around if the practices can know what the quote normal baseline is supposed to be, then modifying and deviating from that becomes that much more important because I think, as you said, it allows you to dig into the data and say, was there some particularly unique condition with that patient, or is it that the understanding of what the normal evidence-based approach is that's evolving? And kind of so do I'm kind of building off of that, maybe going in a slightly different direction is, do you see some overrides because maybe one practice just has its own particular way of doing things? Because it's, I've heard oftentimes it's, every organization thinks that its approach to care delivery is the best way to do it, or, that it's how they're going to follow it. And that's, where you can have some difficulty in implementation because everyone wants so much variation.
Yeah. So I mean, that is, of course, an interesting problem in and of itself. And what we found, which I think is kind of worth reflecting on, is a common objection you might get is the one you shared, which is, we need to develop a common standard of doing things before we put a system like this in. Otherwise, what's the point? And you look at that across potentially multiple hospitals in a group, and they'll have 20 different ways of doing things. And it's a really important conversation. But actually, what matters more is not that one person is wrong or right, or that one group does things one way, or another person or another group does things another way. What matters is that there is a cohort, however you define the cohort, of people doing something in a particular way that you can measure. So it's not so much that you need to conform everyone to a common standard and say that's it. What you need to do is create these sort of coalescing cohorts of behaviors that you can then start tracking and say, well, the way Matt's doing it over here actually is delivering better outcomes as defined by these measures, whereas Robbie's way is crazy, but it works really well for these 3 patients. So we actually then should look at our best practices and say, well, if we see that kind of presentation, we want to apply Robbie's approaches, but in every other circumstance, we want to apply Matt's approaches. And so from our perspective, it's actually sometimes interesting to have some of that variation, provided that it is provided that it's internally consistent. Where people are going off making random decisions, doing random things, that's not going to be helpful. But candidly, people who do that tend not to be our customers in the first place. They tend to have got to a level of maturity where they understand the importance of reliability and the need for applying best practices at scale and the consequences that brings.
Yeah, and that raises a great point because with that, as you teased out that example, it's if you can develop those data points from the variables and from the variations, then you can see where, as you said, pursuing that different approach is going to be most impactful. And it goes back to your earlier point of you need to establish, or you don't need to, but it's most beneficial to establish a normal baseline that is going to fit the needs in the majority of cases. And then you're able to, it sounds like, probably more effectively determine where additional personalization is required based off of how a patient is presenting.
That's right. So that, to me, the key is not to try to, as I said, shoehorn everyone down the same process. The key is to enable a platform for radical personalization. But that personalization comes from consistency of decision making, and that decisioning requires that you have a protocol and a process. You have to understand what you're doing. The issue is that we have unwarranted variation where people are inconsistently doing potentially the right thing or the wrong thing, but you get identical patients coming down the line and you end up with differing outcomes because you haven't had that consistency. And like I said at the top, that's less of a problem these days around the clinical side, but it's very much a problem on the operational side. And you end up potentially with clinical compromise as a result. So coupling the two together is absolutely foundational.
Yeah. So kind of to that point, as you've been able to, hopefully drive better understanding and adoption of combining those two, kind of what was maybe one of the most surprising challenges that arose as you were trying to drive those better connections?
It's kind of interesting. Like, everyone looks at the world through their own lens, and what always surprises me is stuff that is intuitively obvious to some people is not obvious to others. And I haven't been able yet to explain it, but we will meet customers who viscerally understand this. Like, they absolutely, completely understand why it's important and how it's transformative for their business, and they will move heaven and earth to get it done. And we'll meet other customers who will say, that's interesting. Yeah, we already do this. And yet then they can't provide any of the evidence that would suggest that they did. So maybe it's on me being unable to explain what we do in a simple and clear manner. That's entirely likely. But it's a very specific thing that I think comes from deep, deep, deep operational understanding of what actually happens on the shop floor in a healthcare organization. And this idea that you can expect teams of people to perfectly coordinate things themselves without inconsistency or without failure is a mystery to me. Medicine isn't that special in that it requires teams of people to operate together. Every organization of any kind has this problem. Where medicine is special is we have to combine a high level of subjectivity at the point of decisioning that requires a personalization that should be carried throughout the process. And that means that you can't get into a situation where you can do the same thing for every patient. If you could do that, it would be easy, but you can't. And so to me, what that says is automatically this is a much harder and more important problem than it is in other industries, because that level of variation and that personalization is what makes it work, but the systems and controls don't exist for it. So that creates a much higher or a much bigger opportunity for solving the problem. But I think when people have been doing things a certain way for a long time, and they've maybe not done anything else, and they accept that that's the way things are, then maybe they don't see a different way or an alternate approach. For others, maybe they've come in from other industry and trained later in their career, or maybe there are certain disciplines like anesthesiology, for example, is one of those areas. If you meet an anesthesiologist, they tend to get this instantly. And I don't know what it is about their training that means that they have this view, but it's really interesting. Anyway, these are some of the things that have surprised me and challenges we've come up with along the way. But there's no shortage of opportunity. That's for sure.
Yeah, no, and I think that's a very good point. And it sounds like it takes a lot of kind of introspection and willingness to critically examine, one's own operations. And kind of that last point of you saying that there's certainly a lot of opportunity, but also a ways to go. I think is a great point to have to conclude on, because unfortunately, believe it or not, we are already out of time. So I want to thank my guest, Robbie Hughes, for a great conversation today. Thank you, Matt. It's been a pleasure being here. And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.